So, hello, good afternoon, and welcome to the Wilmot Cancer Institute Community Conversations on Cancer series, sponsored by the Office of Community Outreach and Engagement and its Community Cancer Action Council, or CCAC. I'm Sarah Merritt, Regional Outreach Manager for the COE and liaison to the Access to Care Rural Integration CCAC Working Group. Thank you for joining us for today's community conversation on cancer titled Anal Dysplasia, What's the Big Deal? Community Conversations on Cancer is an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. Over the course of these series, topics will address social determinants of health, improving cancer care delivery, and promoting health equity across our 27-county catchment area. This live event has been approved for one AMA PRA Category 1 credit, one CNE credit for nurses, and one contact hour for social workers. Our presentation today will be followed by a live Q&A session. Throughout the presentation, please feel free to enter any questions in the Q&A box at the bottom of your screen. Now, I am pleased to introduce to you our presenter, Dr. Tim Zhu. Dr. Zhu is a surgeon specializing in colorectal surgery. He is an expert in colon, rectal, and anal cancers, minimally invasive surgeries, inflammatory bowel diseases, and more. He received his MD and Master's in Public Health from the University of Rochester and completed a fellowship in colon and rectal surgery at the Cleveland Clinic Foundation. Dr. Zhu grew up in Rochester and works here to give back to the city and the people that made him who he is today. He believes that all patients deserve the chance at living their best life. He is here to help them get there. I will now turn it over to Dr. Zhu.
Thank you so much. It's a pleasure to be here. Thank you so much for the opportunity to participate in this wonderful opportunity. So I'll be talking about anal dysplasia today, and hopefully we can all learn a little bit something about anal dysplasia, which is a topic that's not talked about very often. I have no disclosures. So we'll be talking about a couple of things. First, we need to discuss human papillomavirus, HPV, and its relation to anal dysplasia, and reason for screening for anal dysplasia, and screening methods, why we treat and how we treat, and surveillance. And I also like to share some information about our clinic and talk about what patients can expect when they come to our clinic. So to talk about anal dysplasia, we have to talk about human papillomavirus. And most everyone will probably have heard of HPV. HPV is the most common risk factor associated with anal dysplasia. And the risk of anal cancer is directly related to the type of HPV you have. There are many, many types of HPV, 30 of which alone have been identified in the anogenital region on humans. The majority of HPV-related cancers involve type 16 and 18. The ones that you see bolded on the screen right now, those are the types that are currently covered by the vaccine available for HPV. So HPV is very, very common. According to the CDC, and this is directly off their website, 43 million HPV infections in 2018. In that same year, there were 13 million new infections. HPV is so common that almost every sexually active person will get HPV at some point if they don't get vaccinated. So why doesn't everyone have an HPV-related issue? Well, because HPV can be cleared naturally by our immune system. Studies show that anal HPV infection can be cleared at a rate of about 90% at 1 year. And this is actually better than cervical HPV infections, which usually takes closer to 2 years to clear. So what are some of the risk factors for persistence of anal HPV? Well, these same risk factors are the ones that are shared for getting anal dysplasia and anal cancer as well. Because clearing HPV depends on our immune system, HIV and other immunosuppression are very high risk factors for having persistent anal HPV infection. Other immunosuppression includes, for example, if you had an organ transplant and you're on lifelong immunosuppressive medications. If you have a history of HPV infection or other HPV-related lesions, for example, women who have had previous cervical, vulvar, or vaginal HPV-related dysplasia or anal cancers, they are at high risk for anal HPV. Men who have sex with men is a high-risk group compared to the general population. Older age, smoking, and multiple sexual partners are all other risk factors for having persistent anal HPV. So the reason we care about HPV and anal dysplasia is the risk of anal cancer. While the rates of colorectal cancers have been decreasing, in the US, the rate of anal cancer has actually been increasing by about 2.7% per year. And the deaths related to anal cancer have been increasing by about 3.1% every year, which is very alarming. Current rates of anal cancer among HIV positive men who have sex with men is actually higher than the rates of cervical cancer that initially prompted the adoption of universal screening for cervical dysplasia. So this is a rather busy slide, but what it does is it summarizes the risk of anal cancer in different patient groups in numbers of cases for every 100,000 person per year. So down here on the bottom, you can see the baseline population of men and women who are HIV negative. And you can see that for HIV positive men, their risk of developing anal cancer is upwards of 30 to 40 times higher than the general population. And for men who are HIV negative, but have sex with men, their risk of having developing anal cancer is about 20 times higher than the general population. And if you combine those two, that is the highest risk group. Patients who are HIV positive MSM have risks of upwards of 60 to 100 times higher than the general population. And what you can see on this chart is that there's also showing women who have had previous HPV infections, like we talked about, that are also high risk. So for example, women who have had vulvar cancers are almost 50 times higher risk for anal cancer. And also women who have had solid organ transplants that are more than 10 years out, again, 50 times higher than the general population. So HIV is clearly a major risk factor here in addition to HPV. So that begs the question, what about treatment for HIV? So the FDA first approved HIV treatment medication in 1987. And studies have shown that HIV treatment reduces the risk of anal dysplasia and anal cancer compared to no HIV treatment. But nevertheless, the risk is still higher than the general population. And what this graph shows is that up top in the blue, yellow, and black line in HIV positive patients, men and women, their overall risk, despite in the era of HIV treatment, their risk is still higher than the general population, who's down here in the purple and the light blue. In addition, the rate at which anal cancer has increased in these different patient groups is higher in HIV positive patients compared to the general population. So HIV treatment, very important, but clearly is not the only answer. So what about protecting against HPV, since that's the other big risk factor? Well, we'd be remiss not to talk about the HPV vaccine, since the University of Rochester actually played a pivotal role in the development of the original HPV vaccine. So the first HPV vaccine was developed in 2006. It was a bivalent vaccine, and it covered the two most common high-risk HPV strains, 16 and 18. And it was approved for 9 to 26-year-old females. And later, a couple years later, in 2009, it was approved for men. The most recent HPV vaccine is actually a non-valent vaccine that covers the strains that I showed you earlier. In between, there was a quadrivalent vaccine as well. This was approved in 2014, and many people actually don't know this, but it was expanded to include ages 27 to 45 in 2018. And many patients are not aware of this and don't realize that they actually still qualify for the HPV vaccine. Many people think they've actually outgrown it, but they haven't. So does the vaccine work? Well, there was a study published in 2020, not too long ago, out of Sweden actually, that looked at 1.7 million women that showed a 90% reduction in cervical cancer rates since the approval of the vaccine in 2006. And this was most pronounced in girls who were vaccinated before the age of 17. So the vaccine clearly works for cervical cancer. The assumption is that this also holds true for other HPV-related cancers, including anal cancer. But the problem is that we can't really study the effect quite yet in anal cancer because the average age for development of cervical cancer is 50, with most women developing it in their 30s and 40s. Whereas the average age for developing anal cancer is actually 65. And it is earlier in HIV positive patients, usually in the 30s and 40s, but that's a much smaller population. And the other problem is that according to the CDC, among adults 18 to 26, only 39.9% of the population has actually received at least one dose, and only 21.5% has received all 3 doses, the full course of the vaccine. In comparison to Sweden, that published that study in 2020, their population is an 80% vaccination rate. So the US really lags behind some other countries in terms of getting their population vaccinated for HPV. So what about other prevention methods to protect yourself from HPV? And these are all good ideas, and we encourage them among all of our patients. But because HPV is transmitted by skin-to-skin contact, barrier protection such as condoms can help reduce risk, but it does not offer full protection. And similarly, limiting the number of sexual partners can also reduce your risk, but it's difficult to know who has HPV and who doesn't. And as you just learned, from a purely number standpoint, chances are your partner has or has had HPV at some point. And smoking cessation can help prevent persistent infection, but obviously does not prevent exposure. So knowing this, what are the symptoms of anal dysplasia? Well, here's part of the other problem, is that the vast majority of anal dysplasia is asymptomatic. Most patients who have anal dysplasia did not know that they had it. It can cause some symptoms like bleeding, itching, feeling of a growth, or pain. But that also mimics a lot of other anal rectal issues like hemorrhoids and fissures. So it's very hard to figure out whether or not a patient had dysplasia purely based on symptoms. So since most patients with anal dysplasia don't have symptoms, could we screen high-risk patients, and could that work? Well, the idea of screening stems from cervical disease again. And in cervical disease, we have clear evidence that it works. There was actually a rather unfortunate study down in New Zealand in the 1950s and 70s where a doctor knowingly withheld treatment for cervical dysplasia in about 130 women. And in that group of 130 women, he found a rate of conversion to cervical cancer in 22% of patients who had cervical dysplasia compared to 1.5% in patients who had normal cervical cytology. And if you look at the rate of cervical cancer in relation to the uptake of pap smear, there's a clear relationship. In this graph, you can see this purple line that shows the screening rate in terms of pap smears. And the blue and red line are the rates of cervical cancer. And perhaps what's a bit alarming, if you look at this is US nationwide data. Is in recent years, there's been a bit of a downturn in the number of pap smears being done. And you can start seeing an uptick in the rate of cervical cancer. The most common cited reasons in surveys of women for why they were overdue for pap smears was simply they didn't know that they were supposed to get one. So education is very, very important, and which is part of the reason why we're here today. Wait, sorry. So who should get screened? There are some patient populations where we all agree they should get screened, and others are a little more controversial. So HIV positive men who have sex with men are clearly very high risk and should undergo screening. Patients who have had a history of another HPV-related lesion, either cervical, vulvar, or penile, regardless of HIV status, are also high risk and should probably get screened. Here at our clinic, we will screen all HIV patients that we meet, regardless of whether they are men who have sex with men, whether they're women, whether they're transgender, we will screen all of them. We will also screen HIV negative patients who are men who have sex with men, and even if they're taking PrEP. The other two groups that we kind of touched on briefly previously, the transplant patients and other patients who are medically immunosuppressed, there's really no guidelines for, and we do have a handful of patients who are transplant patients in our clinic that do have anal dysplasia, but again, there's just not enough data for it yet. So what are your screening options? So there are a couple. There's the digital anal rectal examination, otherwise known as DARE. There's anal pap cytology, and there's HPV testing. So we'll go through those a little bit. So what's a digital anal rectal exam? It's exactly what it sounds like. It's a finger exam of the anal canal and of the last portion of your rectum. It is the most basic screening that anyone can do. If you have a finger, you could do it. It should be done in conjunction with a visual exam of the surrounding skin because dysplasia can happen on the perianal skin as opposed to within the anal canal. The official New York State recommendations is that all patients over the age of 35 with HIV should have a DARE done annually, or any patients with anal rectal symptoms. Again, in our clinic, if you're HIV positive, even if you're not over the age of 35, you're going to get a DARE. And it's very important to remember that a normal digital anal rectal exam does not mean that you are free of dysplasia. And we'll talk about that a little bit later on. Anal pap smears. So anal pap smears are exactly the equivalent of cervical pap smears, except in the anal canal. We take a cotton swab, or not cotton swab, usually it's a synthetic fiber, sorry. And we swab the anal canal for cells, and those cells are looked at under a microscope. It's a very, very effective screening method, and is our preferred method in conjunction with the digital anal rectal exam. For providers who do it out in the community, it's really, really important that the anal pap is done prior to any sort of digital anal rectal exam, or really any swabs or lubrication or any creams that you may want to put on into the anal rectal region to maximize the yield of cells. And patients should be advised to ideally avoid any enemas, douches, anal intercourse, or anal insertions for at least 24 hours prior. It's a relatively simple and quick test with minimal discomfort, and it's cheap. About HPV testing. HPV testing can be very useful, but it's not a good standalone test. It's really best done in conjunction with an anal pap. Part of the problem is that HIV patients have very high rates of high-risk HPV. And the presence of their HPV does not necessarily correlate to whether or not they have dysplasia. So ideally, the HPV testing should be done if the pap comes back abnormal. So let's dive into dysplasia a little bit more. So to discuss dysplasia, we have to discuss some terminology. So dysplasia has really been broken into a two-tier system. There's low grade, or otherwise known as L-cell, and high grade, or otherwise known as H-cell. There is some older terminology referred to as AIN. AIN1 refers to low grade, and AIN2 and 3, as you see here, refers to high grade. Even though this image shows what appears to be a gradual transition from normal cells to low grade, then to high grade, then to cancer, it doesn't quite work like that. And there's no evidence that low grade will actually become cancer. We do have evidence that high grade will become cancer, though. I also want to point out that condylomas are low grade, even though they look very ugly. Condylomas aren't cancer and don't typically become cancer. So why do we care about low grade dysplasia then? Well, low grade dysplasia is a marker that the patient has an HPV infection and therefore is at risk of having high grade dysplasia. So even if your anal pap comes back with low grade dysplasia, unfortunately, we have to take a look. So what's actually the actual risk of high grade becoming cancer? There's a few studies that have looked at this. These were two kind of rather nice studies. The first study was done in 27 HIV positive men who had sex with men who refused treatment for their high grade dysplasia. And the researchers simply asked, can we at least follow your lesions? And what they found in this group was that the average time of progression from high grade dysplasia to anal cancer was 46 months. And another study showed that the 5-year risk of progression from high-grade dysplasia to squamous cell cancer in HIV positive patients was 14.1%, and in HIV negative patients was 3.2%. So you did the screening, and now you have the results. What do you do from there? Well, if it's normal, great, congratulations. You can just continue your annual screening. If it's an adequate sample from an anal pap, then we would suggest repeating the cytology or repeating the anal pap. For pretty much everything else, you can refer them to us and we will take care of it. If the patient has a abnormal digital anal rectal exam, unless if it's an obvious hemorrhoid or fissure, even then, you're welcome to refer them to our colorectal clinics. We see those as well. But if you do a digital anal rectal exam and you feel something and you're not sure what it is, feel free to send them to us. If the patient's cytology comes back with LSO or low grade or AIN1, send them to us. High grade, AIN2, 3, send them to us. The one that really confuses people is ASCUS, atypical squamous cells of undetermined significance, because, well, it's undetermined. What does that mean? Well, it means that we need to take a look. So those patients should get referred to us as well. And sometimes you'll see on the pathology report, blah, 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 can't rule out high-grade dysplasia. If they say that, send them to us. Or if you're a community provider and you're not comfortable doing the screening, we're happy to be the access point for screening. We encourage community providers to do the screening. We're happy to educate, but if need be, we are more than happy to be the access point as well. So what happens when patients come to us? Well, the next step after screening typically is high resolution anoscopy. And what is that? That is analogous to colposcopy for cervical dysplasia, where we basically take a look at the anal canal with a microscope. It is office-based typically, and we use it for diagnosis and treatment. And you need a microscope because only about 38% of abnormal lesions are actually visible to the naked eye. So what do we do during the high-resolution anoscopy, which is otherwise known as HRA? So we will typically insert an anoscope so we can actually see inside the anal canal. And we will apply different stains essentially to highlight areas of the anal canal that are abnormal. Here you can see that the normal tissue should be pink, and the stain that we apply, which is actually a vinegar-based solution, turns the areas that have dysplasia white. And we can further differentiate low-grade from high-grade dysplasia using an iodine-based solution, where you can see here, this pale yellow right here is more likely to be high-grade dysplasia than these lesions over here where they're darker brown. And during the high-resolution endoscopy, the first time we see you, we'll typically start with a biopsy so we can make sure that's actually high-grade dysplasia. Because one of the things that we don't want to do is that we don't want to overtreat. What we know is that patients who have high-grade dysplasia, they're at high risk for getting more high-grade dysplasia and requiring further treatments. So we don't want to just treat any old lesion that we see necessarily, because every time we treat the anal canal, there's a potential of causing some scarring. So we really want to make sure that we target our treatments. So what does treatment look like? Well, the goal of treatment is to reduce the rate of progression to anal cancer while preserving function and minimizing the side effects. So really, there's two options. There's topical, which comes in the form of something called Miquelmod, and another one called 5-FU. And there's local ablation, which in our office, we have two options, electrocautery, otherwise as known as a hyfricator, or infrared coagulation, otherwise known as IRC. Topicals play a very important role. Some patients, for whatever reason, may not be able to tolerate local ablation or have disease that's not quite amenable to local ablation quite yet because perhaps there's just too much of it. A lot of times what we'll do is we'll use a topical to try to decrease the volume of disease before we consider local ablation. The recurrence rate is a little higher than treatment with local ablation. And the other problem with topicals is that some patients can get really, really bad skin side effects from the topicals that actually makes it so that we have to discontinue the topical treatment and pursue other options. Local ablation is really considered the gold standard. In our office, we typically like to do electrocautery with a hyfricator. It's a little bit quicker, which means the patient's on the table for less time. There are some patients where we do have to use the infrared coagulation, particularly in patients who have mechanical devices like pacemakers or sacral nerve stimulators. If you have an artificial joint or you have a ring or some sort of jewelry that you can't remove, that's okay. But for patients who have actual electronic devices implanted in, we really want to make sure that we don't send a current through those. So we will use the infrared coagulator for those patients. So I think at this point, you've been actually taking my word that treating high-grade dysplasia will actually prevent cancer. So does it actually really? And luckily, there was a pretty big study that came out just last year that does show that treating high-grade dysplasia can prevent cancer. And this was what's referred to as the ANCHOR study. And ANCHOR stood for the Anal Cancer HSIL Outcomes Research Study. And this was a national study funded by the National Institute of Health. It was a trial that randomized just about 9,000 patients. And this was done at 25 different sites across the US in HIV positive men and women who had biopsy-proven high-grade dysplasia. And half the patients were randomized to treatment with some sort of local ablation, and the other half was treated to just observation. And what they found in the study was patients who were treated for their high-grade dysplasia had a 57% reduction in the risk of anal cancer compared to patients who were not treated. So a pretty important study that just came out recently that really solidifies that what we're doing is very important. So treatment is important, but follow-up is also very important. Non-adherence to surveillance and treatment is a significant predictor of progression. Some studies show that the rates of non-adherence is up to 67%, which is a lot of patients. That's 2/3 of the patients not following up as they should. Our clinic will typically perform repeat HRAs about 3 months after treatment to assess for treatment response and any additional lesions. And those are normal, then we can start spacing them out to eventually to annual anoscopies for patients with a history of high-grade dysplasia. There are multiple reasons that seem to contribute to the high rate of non-adherence for this. There's certainly seem to be a lack of knowledge and concern regarding anal cancer, and not even necessarily for the patients, but also among providers. There is a lack of access. HRA has a very steep learning curve, and they have to do a certain number of HRAs to be good at it. This is an anal rectal problem, and some patients get very embarrassed, and there still is stigma surrounding anal rectal issues, HPV, HIV. So that's a big barrier to overcome. And this there's certainly distrust of medical professionals. Patients who are afflicted with anal dysplasia have tended to be marginalized communities with very good reason to distrust medical professionals. And that's certainly something that we have to continuously work on. And other patients are just afraid of the discomfort of procedure, or their first experience, they experience that discomfort and is hesitant to do it again. In regards to the education piece, there were actually a couple of survey studies that was done in New York City, where they found that 60% of surveyed men who have sex with men knew they were at risk for HPV. But actually, only 30% of them knew there was an association between HPV and anal cancer. So clearly a knowledge issue here. But what I think is actually scarier is that there was a survey study of 58 HIV positive MSM patients, asking them had they ever heard of anal cancer, and only 5 of them said they ever heard of anal cancer from their doctor, which I think is really a scary part because patients depend on us to provide them with that education. So what can we do to increase adherence? So education is obviously very, very important. And as I said, this isn't just necessarily a patient education issue, it's also a provider education issue. Teaching providers what the risk factors are, who to screen, when to screen, how to screen, and when they should refer them to a specialist. And the other big problem is accessibility. We are very lucky in Rochester to have HRA providers and an anal dysplasia clinic. Many cities our size do not have that kind of service. And the other issue is that how do we get the screening to patients? One of the things that is frequently looked at is, should we bring screening to the at-risk patient populations, or perhaps home screening is an option, like anal self-exam. So that's all been discussed. So our clinic, we see over 1,000 patients every year. We have two nurse practitioners who are certified for high-resolution endoscopies, Kathy Drogan, who is on the panel today, and Lindsay Rufo. And they're both wonderful. We also have a dedicated nurse, Denise Emmett, who helps keep the clinic running and helps room all the patients and bring them in and screen all the patients. One of the great things about our clinic is the clinic is fully integrated and collaborates with the colorectal surgery department. I'm the medical director, so if there's something that can't be handled in the clinic, they come see me and I will take care of it. So there's really no lag in care at all. And there's no question, okay, well, what do we do next? Because we have an answer for that. So at this point, actually, I would like to turn it over to Kathy Drogan to kind of discuss what patients should expect when they come to our clinic. Kathy?
Thank you, Dr. Xu. Hang on, I'm sorry. Okay. Thank you, Dr. Xu. Hi, everyone. Thank you for joining us today. Once you come to our clinic, we want you to know that our primary goal is for your comfort, your privacy, and providing you with expert care. And we make special efforts to maintain privacy and confidentiality at all times because we know how important that is. Because we realize that there's a lot of anxiety about this exam. It can be embarrassing. It can be scary. People can be afraid of having pain or what we might find during the exam. So we really spend time with you and we explain everything and we make sure that you feel comfortable in your surroundings with us. There is no prep for the exam. You don't need to do any prep like a colonoscopy. You can eat before you come. We're not going to sedate you, so you don't need a driver. So it's not like a colonoscopy that you may have heard of or had before. The next slide. So we are located right in the hospital on the second floor in the ambulatory tower. So you come up to the second floor and you'll check in at the surgery clinic desk. Then our nurse Denise will come out and get you and bring you back to a private room where it's just you and Denise, and she'll take your vital signs, review your allergies and your medications. She'll ask you a few questions about any symptoms that you might be having. And she'll review the procedure for the HRA or the high resolution endoscopy exam. It's just you and her that are in this room. And once you're completed that part, then she'll walk you back to the procedure room, which again is a private room. It has an attached bathroom where you'll go in and you can change into a gown. And then you will come out of the bathroom and into the procedure room where you'll meet the nurse practitioner, either myself or Lindsay, who will be doing the exam. Next slide. So one of us, either Lindsay or myself, will talk to you first and we'll review your history. We'll explain the procedure and we'll answer any of your questions. And then we'll ask you to sign a consent for the procedure. There is one other person in the room with us. Usually it's a technician who helps us during the exam, and we have both female and male technicians. And so if you are a female and you prefer to have all females in the room, you just let the nurse know, let Denise know when you are coming in, and then we can make sure that the tech in the room is a female. And then we'll get you comfortable. We're on the exam table. Typically, patients lie on their left side. We cover you with a sheet or a blanket, and you have pillows for your head. Excuse me. And on the average, the exam takes about 15 minutes. We use numbing gels for your comfort. Excuse me. Excuse me. And if you need a biopsy, it would be done during the exam. And we give free parking vouchers with each visit. So then once you're done, you can check out and you can be on your way. And then we call you with the results of the exam. And I think that was all I had to say.
Thanks, Kathy. The only thing that I will add is what's kind of exciting for us is that we'll probably be moving to a new clinic space as of 2024. So there'll be a brand new space where you don't have to worry about parking because we'll be moving to Sawgrass. So don't have to worry about parking vouchers in our new space. So that's kind of the overview of what to expect when you come to our clinic. So again, what I want to emphasize is that, dysplasia is really something that has to be talked about, and the education needs to be shared among providers and patients because we have screening methods and we have treatment methods. So spread the word, and thank you for everyone joining us for this seminar, and we're happy to take any questions. Sarah, I think you're muted still.
Yes, I was. Thank you. Well, thank you both for that presentation. That was great information. We have a variety of questions that came in, so we'll start the Q&A. The first question is, can the HPV vaccine work for ages 45 and up and sexually active?
That's a great question. And truthfully, we don't know. So the sexually active part, if you are sexually active, let's first start with 45 and under. If you're sexually active or you've had HPV infections in the past, that doesn't matter. You should still get the vaccine because the vaccine covers multiple strains. So even if you've had one of the strains, the vaccine could still be covering you against those 8 other strains that's in the vaccine. Now, for patients who are 45 and older, there's just not enough data for it quite yet. If you want to ask me for my personal opinion, I think you should. And I have had patients who have paid out of pocket to get the vaccine over the age of 45. I still think that it confers some benefit because it doesn't quite make sense to me why 45 will be a cutoff where suddenly the vaccine doesn't work for you. HPV is HPV. So my recommendation would be if you feel like you are potentially high risk, even if you're at the age of 45 and you're financially able, I would still get the vaccine.
Great, thank you. All right, the next question is for you, Dr. Zhu. Do you have any recommendations on how to convince men to get the vaccine?
Boy, that's like a philosophical question, right?
$1 million question.
That's a tough question. It's I don't have any great tricks. I spend a lot of time with patients who come through my clinic with anal dysplasia because I do find that there tends to be a pretty big knowledge gap of what HPV is and why it's important. Because, like I said, at the end of the day, it's an asymptomatic problem. Patients don't know they have HPV. Patients don't know they have dysplasia. What doesn't hurt them doesn't bother them, right? So for me, it's really about discussing why treating HPV is important, or I'm sorry, not treating, but vaccinating against HPV is important, and why treating dysplasia is important. So do I have a magic bullet for men? I don't. And frankly, it's not just men. A lot of women are resistant to getting the vaccine as well, because again, there's this stigma around HPV that is a sexually transmitted disease, and that if you have HPV, it's somehow bad. But I try to explain to people, listen, 85% of the population is going to get HPV. Statistically, you have HPV or you've had HPV at some point. I've had HPV at some point. Maybe I have HPV now, right? So I try to really approach it that way to try to encourage people to get vaccinated and get screened.
Great, thank you. All right, the next question is anal dysplasia more prevalent in men or women?
Yeah, so anal dysplasia itself is actually more prevalent in women. although HPV is more common in men.
Oh.
Oddly enough, especially high-risk HPV tends to be more common in men. Women tend to have more kind of prolonged HPV exposure because of their, the cervix again is kind of like the anal canal is hidden, right? For men, when they have genital urinal HPV, it's just out on the surface, right? It's just on the skin, so you can see it more readily. So for that reason, I think HPV is actually more commonly missed in women, and they have more persistent infections.
Interesting. All right. Did you want to add anything, Catherine?
Oh, no, I'm sorry.
No, you're fine. All right. Next question. Can people who have tested positive for HPV still receive the vaccine?
Absolutely. So I kind of alluded to earlier, the vaccine covers 9 strains. Now, the downside to the vaccine is that there's no cross coverage. So the nine types that are in the vaccine are the 9 types that the vaccine covers. It does not provide coverage for any of those other types that are not listed. But nevertheless, chances of you having had all 9 of those types is probably low. So even if you've had one of the types, even if it's one of the high risk types, it's still worth getting the vaccine because you're still getting that protection against those other types within the vaccine. So 100%, if you've had HPV infection, doesn't matter, I would still get the vaccine.
Okay. And next question is, can you get anal dysplasia without having HPV?
Yes, you can. You can get anal dysplasia without HPV. It's the association between HPV and anal dysplasia is upwards of 91 and 95%. So statistically, it's going to be HPV related, but you can get dysplasia without HPV. Yeah.
All right. Now the next question is, what is the rate of anal cancer and treatment outcomes for Black and Latino men who have sex with men?
That's a very good question. I do not know those rates off the top of my head. But what I will say is for anal cancer, all comers, especially for anal cancer that's caught early, the survival is very good. We can get a cure upwards of 80%, greater than 80% of patients who come in with anal cancer. The problem is when you have advanced anal cancer. The survival for advanced anal cancer drops off significantly. So again, this is why prevention and screening is very important. It's much like any other cancers. The earlier you catch it, the better your odds of surviving it and being free of it. And just because you have, and some people might not know this, just because you have anal cancer does not necessarily mean you need surgery. In fact, there's a lot of patients that don't need surgery for anal cancer. So catching it early really provides you with a lot of options in terms of treatment. Now, in terms of the outcomes in Latino and Black patients, I don't have the numbers on the top of my head, but what I will say is it's pretty well documented that anal dysplasia and anal cancer is more common in racial minority groups, partly because of access issues and partly because of just not having been told of the risk of HPV and dysplasia and anal cancer. And like I said in the talk, patients who have anal dysplasia has traditionally been very kind of marginalized groups, like racial minorities. So it's a group that we really have to put a lot of attention on, and probably requires kind of more focused outreach to improve screening and treatment.
All right. All right. And the next question is, it sounds like the clinic takes patients once anal dysplasia has been found. So what does the test to determine dysplasia? Who does the test?
Yeah, good question. So as I kind of said in my talk, while a lot of our referrals are for patients who have already been screened, usually by a community provider, like an infectious disease doctor, like an HIV doctor, or some of the primary care physicians out there who do this. we are happy to be the ones to do the screening as well. If you can't find a provider that is willing to screen you and you feel like you are at increased risk for dysplasia, we are happy to see you and we're happy to screen you. So we can provide that service as an access point to the service. But most of our patients do come from referrals from gastroenterologists, primary care physicians, and HIV doctors.
Okay. All right. And do you need a booster for the HPV vaccine?
You do not. There's no booster for the HPV vaccine. It's 3 shots, and that's it.
Okay. And you need all 3 shots, correct?
You should get, yeah, you really need all 3 shots to get the full effect of the vaccine. Yep. Okay. And as the CDC data shows, the rate for the first shot is not bad, not great, but not bad. But for the population getting the full course, the number is actually terrible.
All right. All right. And what is the out-of-pocket cost for the HPV vaccine, and can insurance cover it?
That's a tough one for me to answer because every insurance company is a little different. So as long as you fall within that group, insurance should cover it. I've had a couple of patients who have paid out of pocket, and the number I've kind of heard is somewhere in the neighborhood of $300 to $400. But again, that may vary, and every insurance company is a little different. So you'll have to check with your insurance company.
Okay. All right. Next question is, does exercise or diet influence the progression or prevention of anal cancer as it may with other cancers that are not anal related?
Yeah, so I don't know. And I don't know that anyone really does. So cancer tends to be so multifactorial, right? And as you allude to, certainly in colorectal cancers, there's abundance of studies about diet and other environmental factors that may contribute to lowering or increasing your risk of colorectal cancers. For anal cancers, we know for sure smoking increases your risk, right? But beyond that, those other environmental factors, they're certainly not as well studied because, again, anal cancer at the end of the day is actually a rare cancer, especially in the general population. So there's not as large of a population cohort to do a study like that. It's not like colorectal cancer. I would not be surprised, right? Over time, as more and more anal cancers accumulate, if someone showed an association, between anal cancer and some environmental factor, I would be shocked if someone didn't do that because that seems to be the trend for other cancers, as you alluded to. But I don't know of any specific associations with diet that would lead to progression of anal cancer.
Okay. All right, next question is, what about people who have had 3 doses of the
quadrivalent vaccine? Yeah.
Yes. Should they get the 9-valent?
That's a great question. I don't know of any studies for that. I think logically they would benefit from the non-valent vaccine because it has types in there that is not covered by the quadrivalent. So the quadrivalent vaccine covers the 2 highest risks types, the 16 and 18, and it actually covers the 2 low risk types that most commonly cause low-grade dysplasia and condylomas, not other high risk types. So I would think that getting the non-valent series will help you protect those other extra types within the non-valent vaccine. Now, is insurance going to cover it because you already received 3 doses of the quadrivalent vaccine? That I have no idea, and it would not surprise me if insurance companies said no.
Okay, good to know. All right, can the HPV vaccine get rid of HPV if you already have it?
So no, it typically can't. There is some data to show that getting the HPV vaccine can slow the progression of high-grade dysplasia to anal cancer. But there's no evidence to show that getting the HPV vaccine will actually get rid of the HPV that you already have. Again, it depends on which HPV strain that you have. And, it also depends on, are you an immunosuppressed patient? Is that potentially why you have HPV? So, typically the vaccine does not get rid of the HPV that you already have.
Okay. And two more. So you said anal cancer treatment may not include surgery. What are the normal treatment options for this?
Yeah. So typically, for anal canal cancers, squamous cell type cancers, which is kind of the most common type of anal cancer, the upfront treatment is actually chemoradiation. And part of the reason for that is because anal cancers frequently involve the sphincter. And for us to get a margin around a cancer in your sphincter, that involves us cutting your sphincter, which most patients do not like, and we don't like either. So the typical algorithm for anal canal cancers is actually chemoradiation first. And there's a very large percentage of patients who actually have a complete response from the chemoradiation. And for patients that have that complete response, they actually don't need surgery. So surgery is typically saved for what we call salvage. So for patients who have progression with the chemoradiation or have persistent disease after chemoradiation, then we would move forward with surgery. For anal cancers that are not within the anal canal and on the perianal skin, for small lesions, there is a role for surgery first because those lesions are more treated almost like skin cancers as opposed to anal cancers.
Okay. All right, and our last question is, what is known about cannabis use and anal cancer risk?
Ooh. I don't have the answer to that one. And I don't know of any studies off the top of my head that have looked at that. That's a great question. What we do know is that a lot of the risks that you get from smoking cigarettes, cannabis kind of has that same risk, especially for cancers. But I don't know of any specific studies that have actually looked at cannabis use and anal cancer risk. That's something I have to look into.
Okay. All right. And is there anything else that either you, Dr. Zhu, or Catherine, that you'd like to add? Any important information you want to leave people with?
Yes. So please call us. If you just Google URMC, anal dysplasia, you will find our clinic. Please call us. Like I said, we are happy to be the first point of contact for patients who have questions or are worried about this. And you may see Kathy, you may see Lindsay. If they're too busy, I'm happy to see you as well. We all kind of work together. This is a very collaborative group, and which is, I think, one of the really nice things about our clinic. And this is something that we're all very passionate about and really want to get out into the community and get people aware of this problem. So.
Okay, great.
I just wanted to say that if you do call us for an appointment and it seems like it's too long for you to wait, just let us know that you would like to get in sooner if you're having some problems, and we'll do our very best to get you in sooner. We have a cancellation list and we do look at it and fill people's appointments from that. So just let us know if you're having problems and you want to come in sooner.
Great. Yeah, good to know. Thank you. All right. Well, I'd like to thank our presenters, both Dr. Zhu and Catherine, for joining us today. I'd also like to thank the interpreters for helping to make this accessible to our deaf community. All of our listeners, please be sure to fill out the survey following this webinar to make sure we are providing content that you are interested in hearing about. This webinar has been recorded, and an email with a link to the video will be sent to all registrants early next week. Any questions that you may have following this, or any that were unable to be answered during this presentation will get answered in this email. And please join us for our next community conversation on May 18th at 12 p.m. All right, have a great day, guys.
Thank you.
Thank you.